my first slide, it just says sex, and then flashes in and says the conversation, and then says scaring parents and providers since 1904.
I'm like, all right, I hope this goes well. I don't know what's going to happen.
Normalizing the use of lubricant.
Erectile dysfunction.
High pressure situation where somebody's grading us, or somebody's saying like, did you get it? Did you get it?
Gynecological issues.
Protection, like condom use.
Female sexual arousal disorder, like
Breast, penis, testicular, and rectal exams.
oh my god, we're going to talk about sex, and like, I'm kind of awkward because now I'm thinking about sex.
A prostate exam, which involves sticking your fingers into someone's rectum.
Oh my god.
You're around talking to patients, asking them questions like, I ask this of all my patients, do you have any concerns about your sexual health? Mm-hmm. What if the patient has a concern and I haven't been trained to answer that question?
My name is Charlie DeVries, and I'm the course coordinator, or one of the course coordinators for Foundations of Patient Care.
Yes, my name is Kat Wentworth, and I'm the executive director of Project Prepare.
Hi, I'm Kevin Keenan. I'm a second-year medical student at UCSF, and yeah, just studying to become a doctor somewhere.
How have you been trained in issues around sexuality?
Well, part of our class is going to lecture and learning about your medical things and like your like biochemistry and genetics and all that. But we also have in our classes something called Foundations of Patient Care, and that is it's about 4 hours a week, maybe 5, usually on a Tuesday or Thursday, and we discuss everything that's more the art of being a doctor and communicating with patients. You kind of learn a lot of common sense things like how to be a nice person and how to be an active listener. And in that, we will start with like learning to take a history, but as we learn more and more, we'll start like, well, how do you take a sexual history?
Well, so I have had the opportunity through my job to get to talk to the students about sexuality, and for the first year medical students, they get 2 hours of lecture. 1 hour, the first hour is on an introduction to sensitive history taking, and that is, I do about half an hour of kind of the basic broad strokes of sexuality and sexual health promotion, and communication around it, kind of identifying one's kind of triggers and boundaries and locating themselves on their own map of like, what's my experience with sexuality and how did I learn about it and how do I feel about it and all of that stuff, and kind of trying to broaden their minds and desensitize them a little bit. After that, they have a small group, which is 2 hours, and they watch a series of vignettes that have sexuality occurring or coming up in clinical practice, and they kind of discuss. The next week they have the proper full sexual history taking lecture, which I do with a physician, Laura Hill-Sakurai. And we go over the more nitty-gritty aspects of sexual history taking, do 3 separate role plays to kind of show the students what it would look like, focusing on different types of patients to kind of use examples for, you know, like the first one is a young girl who doesn't really have the language to talk about it, has a lot of shame, is very quiet and can't really express what she needs. And the second one is a beginning to transition trans man seeking hormones. And then the third one is an older woman who is having a non-monogamous relationship with an outside partner and all of that stuff. And then after that, they have a standardized patient come to their small group, and one of the students actually has to take a sexual history. we ran 2 separate cases last year. One was, I think it was an older man who had sexual dysfunction. I don't remember that one exactly. The other one is a trans woman case that I wrote last year and was so popular that my faculty was like, well, do you want to just use that one only this year? So that was exciting, but I have a little concern about only having LGBT stuff related to sexuality, because I don't want to conflate the two. I know it happens a lot in our students' brains, so I'm really wary of that. And so that's essentially what they get in first year.
And so in the first year, we covered just some basics of like human sexuality within a primary care visit. And then we learned like how do you ask questions about sexuality. In the second year, we've done more hands-on things in that we've been trained how to do a genitourinary exam. We've done both male and female. And those are through the Project Prepare teachers.
Project Prepare is an organization of about 30 educators. So we contract with the schools to teach the students how to perform genital exams. That's the primary thing that we do. So we have male educators who teach breast, penis, testicular, and rectal exams, and female educators who teach pelvic and breast exams to second-year medical students. And so this is their first time ever doing the intimate exam, doing the genital exam. And our educators work usually in groups of 2 or 3 students and 1 educator for 2 or 3 hours. So it's very intense, it's very personal. The students are allowed to have plenty of time and plenty of space to work out their own anxieties around performing those exams, so that they'll feel comfortable when they get with real patients.
Right.
So the first part is always just talking to the students about how to alleviate patient anxiety. And a lot of those issues related to genital exams are issues around sex and sexuality. So that's one place where we begin to talk about sexuality with medical students.
And you go in and you're just kind of immediately put at ease by these teachers, and they kind of run the show, and you're along for the ride, and you're allowed to ask questions as much as you want. And I can honestly say that that was one of the most, one of the best learning experiences, in that, say you're listening for a heart murmur in a different patient, and you've got your preceptor there who's teaching you, and they'll be like, do you hear it? And after 3 tries of not hearing it, you just hit, yeah, I hear it. And so you can kind of just move on because you feel stupid for not getting it.
Yeah.
There was one part during the female pelvic exam where I was trying to feel the ovaries, and that was a really awkward physical position, and I didn't feel it. And Project Prepare seemed special to me because they actually made me comfortable enough to admit it. Like 3 tries into it, like, I still don't feel this, and I kind of feel like this is such a valuable learning opportunity that I'm not going to get in the future. Like, can we keep working on this? And they create that space. It's really helpful.
Well, I think a lot of them share the same concerns that practicing physicians do, where it's a scary topic, and it's not something that we really talk about in American culture anyways. I mean, it's everywhere to see, but we don't really talk about it. That's scandalous, having like frank and honest conversations.
Well, probably the biggest fear that the students have is that they will hurt patients. I mean, there's a fear of the physical exam skills. And then second, or a close second to that, is their fear around talking to patients, asking them questions.
Right, well that's kind of the general gist of medicine, is it's very focused on like, what's your chief complaint? What brings you into the office today? If you have pneumonia, do I need to take your sexual history? Like, how is that related? If they don't think that it's directly involved in the chief complaint, they're not going to ask about it, because that's not their focus. They need to get the patient better. And 2, even if it might be, like, even if there is a medication that has sexual side effects, or if they have a condition that, might be interfering with their ability to be sexual, it doesn't always come up because there's an awkwardness about talking about it. You know, a lot of physicians fear that the patient's going to be offended, particularly if they're of a different gender or if there's a significant age gap. So younger physicians in particular aren't really comfortable about asking older people, and older people in general don't get sexual histories taken at all. Which is also true of people with disabilities. And so if it's not, there's just a lot of barriers and not a lot of incentives, because the other thing is that a lot of doctors wouldn't even know what to do with that information even if they got it. So it's better just not to ask.
It's not always that everyone leaves feeling competent, because I can't run 4 scenarios with a student and then have them feel like they're prepared to face every issue related to sexuality. Sometimes they feel overwhelmed. How am I going to fit this in with sort of the medical system that they're preparing themselves for? Time is always an issue, and addressing sexual health concerns quickly can seem very daunting. It is an extremely exciting time to be involved in medical education. I started as an educator with Project Prepare in 1999. I've been the director of the program since 2001, and even in that 11-year period, there's been a huge shift towards training doctors to treat patients. And I believe that the students value integrating sexuality and sexual health into their practices.
The culture started to change, and I think now, you know, I mean, the younger generations are much more comfortable with sexuality and sex and LGBT issues and stuff like that. And so I think it's a broader general shift, broader cultural shift, but it's starting to happen, and I think it's starting to kind of to change. And I think the fact that there are journals, like there's a Journal of Sexual Medicine, and you know, there's more academic stuff happening around sexuality and sexual health. I think that also helps, because the medical profession tends to be very focused on research and having evidence-based practice.
And like I said, they're a resource. They don't have to be the cure for the deeper sort of emotional health stuff. But a lot of times just a normalizing, you're not alone, you're not the first person I've ever heard who had that sexual concern, can do a lot for empowering the patient to feel better in the moment and maybe seek some other sources of, you know, information, conversation, help.
Baby, I'm hot just like an oven. I need some loving. And baby, I can't hold it much longer. It's getting stronger and stronger. And when I get that feeling, I want sexual healing. Sexual healing is good for me. Makes me feel so fine. Helps to relieve my mind. Sexual healing, baby, is good for me. Sexual healing is something that's good for me. Whenever bruises, drops are falling, and my emotional stability is leaving me, there is something I can do. I can get on the telephone and